about the paper. One of the things that you didn't mention, maybe because it really wasn't well outlined in the Affordable Care Act, and it really didn't get the press when you were writing this paper as it is right now, is the concept of accountable care organizations. So how do you, and for people who may not know what accountable care organizations are, it is the attempt to change the healthcare delivery model in this country from individuals to a vertically integrated healthcare delivery system with all aspects of healthcare, including hospitals, in the mix to try to integrate information so that it ostensibly decreases errors and duplication of services, cuts down on that so that it saves money and delivers better health care to patients. That's the ostensible goal. What critics of this are now saying is that this is really an HMO on steroids, this whole concept of accountable care organizations. And by consolidating, they're not saving money, but creating a mechanism for costs to actually go up. So that's the 2-minute elevator speech about accountable care organizations. And so I throw this back to Dr. Fodeman. If you were rewriting this paper today, would accountable care organizations be part of this, and how would you address that? No, you can. I think this is small enough for him.
Okay, well, very great question, and unfortunately I only had a month to write this, so not everything that I would have liked to have, gotten in there did, but it's a great question, and I agree. I mean, ultimately there has to be something done to lower costs, but I think what the ACO will do is it's going to basically further push hospitals, doctors to vertically organize, and there's enough more than the ACOs per se as well that in this legislation that'll do that. And I don't really think that's such a good thing for physicians. It's basically going to have more administrators, more business people looking over physicians' shoulders, and I think it will be a way to implement this law, but I don't think it's necessarily a good way to implement quality care for patients. And I think also, the rules just came out, and it kind of, forebodes bad things to come. 6 pages of ACO translated into 429 pages in the Federal Register, and 2,800 pages is just going to, down the line, to generate to hundreds and hundreds of thousands of new pages that physicians are going to have to comply with, and ultimately, I don't think it's going to result in good care for patients, which should be the most important thing.
Anybody can chime in, otherwise I'll keep asking questions. Anybody else have any?
Question for Jason. Jason, do you think that Republican leadership would have put together a similar bill to what we're advocating now without Obamacare? Because there's been some criticism that we're responding to Obamacare, but if medicine was broken before, why weren't we advocating these changes on its own, like individual leadership rather than in response to this situation?
I mean, that's a great question, and I think throughout this whole ordeal that conservatives, Paul Ryan, the leadership minority at the time, they did have healthcare proposals to, better healthcare. It's just a different way of doing it, expanding HSAs, tort reform, trying to empower patients, creating more of a level playing field with regards to deduction, creating a national market for health insurance. And unfortunately, during the debate, for whatever reason, those ideas seem to be a lot less newsworthy and didn't get the attention that the president's platform got, unfortunately.
I actually have 2 questions. I want to follow up with a question or a comment that this gentleman stated. I'm certainly not in favor of the Obamacare, but there are certain parts of that bill that are good. 2 of them that I do like is, and I have a daughter that graduated from college, last year, and she was dropped, and she was going through several expensive tests at the hospital, which cost thousands and thousands of dollars, which would have put myself and my wife in some real debt. I thought the age requirement up to 26 was a good thing, especially when young kids graduated from college. The other thing was those individuals that could not get insurance because of pre-existing conditions. And I know Senator McConnell said that that was a good thing, that they would support something like that. So I think that's good. So when I hear Congressman Price say across the full spectrum it's bad, I would have to disagree on some aspects, that there are some good things in that bill, which I'm hoping, if it does get repealed, that the Republicans, and what you said, would pick up and replace, because I think it's extremely important. You said, Doctor, that one thing about Obama did was he outlined that there needs to be healthcare reform.
Yes.
And I would agree with that. I've been in healthcare for 35, 36 years, and on all aspects and a lot of specialties I've worked with. And I will say that this country is suffering from severe healthcare drawbacks that I believe that needs to be corrected. So the Democrats won on this one. I don't have much hope that it's going to be repealed based on the news. But let me say this too. The House of Medicine is severely divided on this issue. The AMA, you had mentioned Dr. Armstrong, the College of Physicians, which you probably belong to, because you're an internist, the American Academy of Family Physicians. They're all support Obamacare. You've got some powerful forces out there, the unions, the AARP, and a lot of forces that are really pushing forward and keep moving forward. Where do you see, as far as some powerful organizations repealing it? I mean, you hear some news, but there are some powerful organizations out there that are going to keep moving forward with us.
There were a lot of questions there. So let me tackle some of that, and maybe we'll get some comments from both of our other panelists. First of all, your points about the good parts about Obamacare. We hear this over and over again, and that's the only defense that we have heard in favor of this healthcare law. And both of those on the surface look good, but there are pitfalls as well. When by extending the age at which you can keep kids on your healthcare policy, what that has basically done, it has destroyed the healthcare market for insurance companies writing policies for young individuals. So I understand it's difficult to get policies for young individuals. It was a problem, but now it's impossible, because that market has dried up. Insurance companies will no longer write policies for individuals. So we've taken care of some people, but at the expense of the entire young marketplace. The second point that you brought up about the good aspects of this law has to do with the high-risk pool. Well, the Democrat leadership predicted that at this point 325,000 people would apply for the high-risk pool. To date, 12,000 have. So we've destroyed, or at least put at risk, the entire healthcare system for the benefit of 0.028% of the population. That doesn't make sense. We could have fixed that one aspect without completely jeopardizing healthcare in this country. And so when we go back to looking at the Affordable Care Act, what's right about it or what's wrong about it, it's wrong, period. Now there may be a couple of aspects of it we can pick up and fix on a go-forward basis, but it needs to be trashed and we need to start over again.
Yeah, I mean, I would echo those remarks. I mean, I think that, this is 2,800 pages. It can't be, adjusted. It can't be repackaged, which President Obama still, is trying to do to this day. It has to be repealed. And as far as some of the, things that you claim is good, as far as community rating, guaranteed issues, those policies, they sound really good, but I think the problem with them is somebody has to pay for them. States that have those policies right now currently have some of the highest premiums in the country. And what happens is basically is that you're a young, healthy person and you can get insurance right now, or you can get insurance down the line when you get sick at the same price, more or less, then it doesn't really make much sense for you to buy insurance right now when you're healthy. So healthier, young, healthy people pull out, you have a sicker pool, costs go up. As that happens, more young and healthy people, pull out, and it basically, spirals into this vicious cycle where costs just continue to climb. And I think a better way to deal with that situation is looking for more consumer-directed solutions, such as, well, if you lose your job, why should you lose your insurance? That doesn't make any sense. There should be a national market for health insurance, just like there is for life insurance, just like there is for car insurance. Why should health insurance be any different? I mean, I think, there are, and I would agree with Dr. Sherris, I would say that the best part of this legislation is that it's shown the spotlight on healthcare, and there are some problems that need to be fixed. I just think that this legislation goes about it in the wrong way and isn't going to make things better, but it's only going to make them worse.
I would just add a couple things to the things you asked. First, tinkering around with that age requirement is just a small part of this whole thing, as Dr. Shears mentioned. We really need to look at the root causes of the problems that have caused healthcare inflation in America, and we need to change the entire way health insurance works in the country. We will not bring down the cost of healthcare and health insurance in this nation until a couple of things happen. First, people need to have some skin in the game, as they say. They need to be responsible for those things that are routine. That's why health savings accounts and high deductible health plans work so well. The market takes over and people can actually make critical decisions about routine care on their own. Mitch Daniels has shown this very well in Indiana with the Healthy Indiana Plan. John Mackey at Whole Foods has shown it on a corporate level with his insurance for Whole Foods. It works. Mitch Daniels was able to bring down the cost of health care for the state of Indiana employees over a 2-year period by 35%. Nobody else has ever done that, and he did it with the HSA high deductible health plan model. People are smart enough to make decisions about routine care. The Obama administration will tell you that patients just aren't smart enough to comprehend how to take care of themselves and spend money on health care. That's completely false. Second, about you mentioning we're working against powerful forces, the American Medical Association, some of the other forces, the AARP. Follow the money. Follow the money. Look at why they supported these laws. There are reasons. The AARP stands to make millions of dollars off Medigap policies. Millions of dollars off Medigap policies because of this law. You know, and we all know in this room, that 80% of the income that comes into the American Medical Association is coming from non-dues sources. What does that mean? The AMA is a corporation looking out for itself, not for its members that pay dues. That's why only 15% of the doctors in this country belong to the AMA, and the AMA does not represent the majority of physicians in America. That's one of the reasons, among others, that they supported this law. Now, they did come out and say that they're against the Independent Payment Advisory Board. Well, great. But you can't fix this law by just extracting the Independent Payment Advisory Board. The entire structure of this law increases the healthcare bureaucracy in this nation, which is the problem. That's why it costs so much. People have figured out how to intervene in the doctor-patient relationship and make billions of dollars from the work that we do with patients every day. It's inappropriate. The surgical societies, the American College of Surgeons and 22 other surgical societies came out against this law too little too late, the Thursday night before the Sunday night that it was passed. Now they've capitulated, I'm sorry to say, and they're teaching their members how to live with this, which I think is, to put it mildly, reprehensible. We need the leadership of American medicine to stand up and say, this is wrong for patients, it's wrong for physicians, because it destroys the doctor-patient relationship, and that's unethical if you're a doctor.
I'm just going to ask a question. It's a little bit off the beaten path. I just want to congratulate you for an amazing paper and really being able to so comprehensively understand something that's so complex at such an early age. And I'm thinking about myself, when I was in medical school, Hillary care was going on. I had no concept that it even came and went. I was studying and trying to learn about being a doctor. I had certain ideas in my head about building a better widget, learning as much as I could, delivering customer service at an affordable price and getting market share and all sorts of these things that I was going to bring to the marketplace of medicine. And then I got out into the real world of medicine and I realized that because of our third-party payer system, I had absolutely no influence on what to charge for my services. I had very little control over how to provide services for my patients because they weren't paying for their services. Somebody else was paying for them. So they would always go to somebody who was convenient to them. They saw all the white coats as the same. And my question is, how is it that you have such an uncanny perspective without having gone through all these life experiences yet?
Well, really.
Just say I taught you
Well,
everything.
definitely a lot smarter than I am.
Well, I appreciate you not noticing my gray hair. I really do, which I got in residency, and actually Robert Cook over there has taught me a lot when I worked at Heritage. But, I always tell people that no matter if you're a conservative, a Republican, no matter if you're a Democrat, no matter if you're a liberal, as a physician, we're so dependent and so probably too much on what the federal government does, on what regulators do. And no matter really what type of the side of the aisle you're on, it's important to stay involved, stay active, because ultimately this is your livelihood. This is your 9 to 5 or significantly longer for most physicians, and it's your bread and butter. So it's really important, to stay active. And even though I have, very limited time in residency, it's something that I feel very passionately about, and try to do what I can.
And I'm tempted to answer your question about pre-existing conditions, but I'll leave that to the panel. But I want to say, following up on what you said, if you look at any other industry besides healthcare, there's an opportunity for providers to differentiate what they do and target different kinds of markets. Now, if you want a car that just gets you where you're going, you can buy a Toyota and not pay as much money. If you want the best, you want to travel in luxury, you can go buy a Lexus, and you'll pay more, but you're getting something that you can decide if you want to pay for or not. And you don't have, and not only can you have different providers, but in the case of Toyota and Lexus, you have the same provider providing two different types of products. You've got the value product and the more high-end product. We don't have any system like that in healthcare. When a patient goes into a doctor, what is going to be paid for that service is the same no matter what doctor they go to. For any given patient, they all have different insurance companies, but anybody covered by Aetna PPO and this plan, whatever surgeon they go to is going to be paid the same amount. You don't have an opportunity to differentiate yourself and say, I'm Dr. Toyota, I'll give you a fast service for less money, and someone else to say, I'm Dr. Lexus, I'll spend much more time with you if you're willing to pay for it. And on the other hand, the customer, the patient, which we don't even call a customer, doesn't have the opportunity to say, I've got a sore throat, it's probably something minor, this time I'll go to Dr. Toyota. And for another patient to say, I've got a sore throat, I have a family history of throat cancer, I'm going to go to Dr. Lexus and I'm willing to pay for it. So you don't have an opportunity to make more money by being a better doctor, or make more money by charging less and getting more and treating more patients. How would you feel about implementing some sort of a system that allows physicians to differentiate themselves from each other and compete on the basis of quality and price, like happens in the rest of the economy?
I'm gonna jump in there and take that and comment. I think that would be an excellent idea, and that's exactly what we advocate for in our prescription for healthcare and everything that we write about and talk about on the website and in forums. I think that there needs to be an open medical economy where there is where there's competition, where there's competition in the marketplace for the insurance product, for healthcare. In order for these things to happen, there needs to be a complete overhaul of healthcare. First, you have to uncouple healthcare from the workplace. So in order for that, so people need to be able to have portable insurance and be able to purchase it, and get the same tax advantages as businesses so that they're encouraged to buy insurance. Second of all, there needs to be competition for insurance, and insurance needs to be redefined. Right now, in this country, in our society, insurance equals prepaid health. And that whole notion needs to be thrown out, and we need to reestablish what insurance was meant to be, which is insurance. It's a hedge. If you look up insurance in the dictionary, you can understand what that means. It's a hedge against an unexpected event. And we don't want there to be a catastrophic outcome for somebody getting sick. So insurance needs to be put in its proper place, and people need to have skin in the game. If you don't have that, forget it. All bets are off. But even in a Medicaid model, if somebody is paying $5, they've got a stake in it. It has worth. Right now, it has absolutely no value to a large segment of our population. Next, what you need to do in order to make this economy work, you need to allow doctors to post fees. You need to have hospitals post fees. It needs to be transparent. But it's not one size fits all for healthcare, and it's not one size fits all for the product that you're receiving. If I'm in practice for 24 years and a new urologist comes out of practice in the first year, why should they get paid the exact same amount for the same operation that I've taken 24 years to perfect? And if I'm better than them, maybe they're better than I am, and that they're going to make more money. But in a competitive market, let the patients decide how they're going to spend their money. And so in order for them to spend their money, they need to have control over their healthcare dollars. High deductible health savings accounts are a beautiful vehicle for that to happen, where first dollar spent is a patient's own money, and then they become consumers. And then they ask questions that need to be asked. Doctor, do I really need to get that expensive medicine? Or do I need to have that CAT scan for my headache? There's an actual consumerism that takes place. Next, in order for that to happen, this economy to happen, you have to take away the yoke from doctors who have liability hanging over their head for the minute a patient walks into their office. Nowadays, patients are not considered patients. They're considered potential plaintiffs. And so that needs to really be eliminated so that the threat of the lottery for a patient walking into an office is eliminated. I'm not saying that there shouldn't be reasonable remuneration to patients who are damaged, but the lottery, the ambulance chasers, this has got to stop. And when you take all of those factors and you address them all in toto, then you have what you're describing, a medical economy that makes sense.
My question for Dr. Frenneman is about your critique of comparative effectiveness research. I understand that you don't want the government doing the research and then dictating to doctors, but is there an organization that is doing, I guess, comparable comparative effectiveness research that doctors trust? And if it's not comparative effectiveness research that's being disseminated to doctors, how do you deal with doctors who are over-treating or who might not have time to be reading up on the latest treatments and what's effective and what's not?
Sure, well, great question. As far as comparative effectiveness research, creating hypotheses, doing research, challenging, perceived norms, that's really modern medicine at the finest. The problem, and doctors do research all the time at, UConn, where I'm a resident at Harvard, from all the way from, Boston to San Francisco and everywhere in between. Research is alive and well. I think the problem is when it's through the government and then down the line, as you're increasing costs and promised savings from things like EHRs, preventative medicine fails to materialize, I think there's going to be tremendous pressure on politicians to lower costs because they're going to explode. And I think down the line, it's going to be reining in our physicians. And the point that I try to make in this paper that, yeah, it's going to be a nuisance for physicians, and it's going to be bad for physicians, but ultimately, it's going to be the patient who faces the restricted access, the patient, who's not able to get the care that they need. And, I don't think that's, I don't think that's a good prescription.
Jason, on that, doctors want that kind of information. We want to be doing what is cost effective and helpful. And if you consider treating the whole patient, which means their body, their psychosocial area, but also means paying attention to their economics, you want that kind of information. The problem is when it becomes coercive. And then you're no longer able to adapt it to an individual patient. That's where the problem with the PPAC comes in. And that kind of, what is cost effective is going on all the time in universities, in hospitals. There's all sorts of quality assurance and quality improvement programs that are in plan. But it ends up being information that then we can take into consideration when applying to an individual patient. That's the way that kind of information should be gathered, not coercively top down, cookie cutter.
That's an important point. See, our job as doctors is to take all this information that's floating out there, and I tell my patients, I don't treat populations. If I cure your cancer, you're 100% cured. If I don't cure your cancer, you're 0% cured. You're not 92% cured. So we treat individuals, not populations. But that research is still important, the data is still important. And that's what our job as doctors in clinical practice and whenever there's academicians around, is to give us that data. We don't need the government doing this. This is what we do. This is our life. So we do this anyway.
Yeah, I got here a little late, but a couple of problems. The doctor who left, I'm an orthopedic surgeon. I was a GP for 5 years, but we are very fragmented. I truly believe if we had 10 or 20 docs walking in lockstep, agreeing across specialties, we wouldn't have gotten to this point. That being said, we have a government or certain people that hopefully they mean well, but I think there's people that don't walk in our shoes who believe that any complex system, be it healthcare, education, any complex problems can be mitigated by more paperwork and regulations, and that's what we've seen, and our hands are tied in our medical staff meetings. That being said, I think we sometimes I'm a simple guy, but I take care of Amish people. There's a couple systems where this is working. An Amish man has never had a vertebroplasty, if you know what that is. They don't work. They sounded good 15 years ago. Or has ever had a volar plate for a forearm fracture. Most people, you don't have to be perfect, you just have to be functional. You're talking about a $500 close reduction versus a $15,000 thing. So my Amish patients are pretty cool. And I take care of a lot of businesses that are tightly managed with occupational medicine, about 10 to 15% of my practice. It's huge. I've taken 1,000 and 1,500 companies from like $2 million a year to $700,000. Just by conservative treatment and knowing 5 words: return to work, modified duty. And my best marketers are my competitors. And finally, I'm doing a cool project with the prisons, except the prisons move real slow. But those are things. Early in my career, I was with Kaiser, and I think we're not. The whole thing about healthcare, is to simplify. It's all about cost. Higher education, healthcare, out of control cost-wise. And I think we all have a responsibility in this new system to think clearly, simply, and just look at the costs. And we should know quality. And I think there's just tremendous opportunities if we. I'm working with some Chamber of Commerce. 3 years ago, I gave up on docs. I mean, we're great folks, but we're very myopic in our views. And it sounds like you're doing some neat stuff, and I commend you. And I think we got to look at quality and costs and keep it simple.
Sure. But I think the question, that you need to ask yourself, that patients need to ask themselves, is when God forbid you or a loved one is sick, who do you want making that life or death decision? Do you want a doctor, someone who spent their whole career studying medicine, studying the complexities, the vagaries of the human body? Or do you want a bureaucrat?
Kathleen Sebelius, an attorney.
Michael Moore.
Of course.
I want Michael Moore to do a story.
You do, huh? You want to take care of you?
He's having a hard time taking care of himself.
I would talk about this comparative effectiveness thing. many of us as physicians have been in with a patient, there's really only one person in the world that has enough information to be able to offer that patient the options that are available to them. And that is the physician who examined them and knows if they're Amish, or knows if they are this or that, or whatever the influences that go into what's valuable to the patient to be able to make their own healthcare decisions. And when you get into this comparative effectiveness board, what happens is somebody who does not have that information is ultimately making the decision for that patient. And that's the frustrating thing. You know, it's interesting. There's a paper that came out in the Journal of Orthopedics years ago that said that arthroscopy was not effective for arthritis. And I'm an orthopedic surgeon too, and I do a lot of knee arthroscopy, and I can show you gradations from a perfect knee to the worst degenerative knee I've ever seen in my life by such infinitesimal increments that who's to say at what point the scope doesn't work? At what point is arthritis so bad that the scope won't work? Well, that comes from judgment. And who has that judgment? Somebody who has scoped thousands of knees, that has seen it over and over again and made the mistakes and tried to do it this way and didn't work, but then did it that way. Ultimately, what has to happen is patients ultimately make the decisions about comparative effectiveness. You can sit down with your physician, you can talk to that person, and the patient will make the decision if this person is taking me to the cleaners or if they're really going to be an advocate for my well-being.
And let me just, I don't know if we're finished with this topic, but let me just throw in my 2 cents. In a perfect world, comparative effectiveness is great because we all want to do the best thing for our patients for the least amount of money, and we want to not do unnecessary treatments. But this is far from a perfect world. And when this information is produced and the government or insurance companies have this information, then they drill down to the treatment that may not be the best, but it's going to be the cheapest. And we've seen that happen in models around the world. We've seen that happen in Great Britain. Now, in Great Britain, the latest headline that came out last week is that prostate screening, and I'm a urologist, prostate screening has no benefit. Well, in this country, prostate mortality is twice as good as it is in England. So it's the old adage, if you don't look for a fever, you won't find one. And that's comparative effectiveness in a nutshell. The other thing is that as long as somebody else is paying for care, then they have every right to say what they will and will not pay for. So if the government is paying for care, they have every right to say what they're going to cover. If an insurance company is paying for care, they have every right to say what they will pay for. The problem isn't that. The problem is that patients need to not only reestablish their relationship with physicians on a doctor-patient relationship professionally, but also financially. They need to be the ones who control how the dollars are spent.
I'd like to ask a question about accountable care organizations. The regulations came out last week, and there were a couple of things that I noted in the regulations that I thought were kind of odd. I'd just like your thoughts from a patient and a specialist perspective. First, that patients will be assigned to an accountable care organization based on the services that they accessed the year before, which seems kind of odd that you're looking back to decide what people's future medical needs are. But then also that the primary care physician is the input for these patients. And I'm just wondering what effect that will have on specialists like a urologist or a general surgeon. If you guys have thoughts on all those regulations, and if you could share them.
I'm gonna let some of the other panelists have a shot.
Well, I mean, ultimately, there's 2 approaches to lowering costs. And one approach empowers bureaucrats to draw lines in the sand, to make tough decisions for patients, to make tough decisions for doctors in a very inflexible manner, and which I think, unfortunately, this was the route the administration chose. I think a better approach to lowering costs would be to empower patients, to put patients in charge, to give patients more skin in the game through the HSAs, consumer-directed healthcare plans, a real national market for health insurance, stuff like that. And I think that's not only going to be a better way to to lower costs, but as my paper argues, I think it's also a better way for patients to get better care.
The ACO model, in a nutshell, is completely unethical because the physician no longer works for the patient. The physician works for the ACO. And the patient doesn't realize that the physician may be denying care to the patient so that the physician can benefit from the bonus that they will get if they deny the care or reduce the cost of that care to the patient, which should be totally antithetical to the practice of medicine. And no one, everybody talks about 429 pages of flowery language and regulations about how ACOs are going to be the savior and it's going to bring down the cost. ACOs build gigantic bureaucracies. Again, ACOs pit physicians and patients against each other. Covert rationing, which occurs all the time right now, is expanded. And they will not work. The other thing that they do is the only organizations that exist right now in the United States that have the infrastructure to make an ACO happen are hospitals or other very large practices that have enough capital and enough infrastructure in their organization to build the ACO. It reduces the autonomy of physician-patient decision-making. It just completely destroys the physician-patient relationship and the private practice of medicine as it exists today in America, and it should be soundly opposed.
But I think to specifically answer your question, Chris, I think that it impacts on specialists because the ACO model makes primary care doctors gatekeepers essentially.
Right.
And so they right now a patient, if they decide that they want to see a urologist because they know there's a urologic problem, or an orthopedic surgeon or a general surgeon, they have to go through their gatekeeper. So it goes back to the old HMO model, which was rejected by America. But this time around, it's now, it's a supercharged HMO, like I like to say, HMO on steroids.
I was going to say that anytime somebody talks about somebody being a gatekeeper of medicine, those of us who practice medicine know that that's a ridiculous concept. I do all sorts of things, and I know that Hal does too, that primary care doctors couldn't possibly know that I have these services available to my patients. But you know who's able to find me right now? My patients can find me because they have a problem. My hip is killing me. What can I do? They get online and they go and they find somebody. And I even now, and I know Hal's the same way, that there are patients out there that are figuring out which doctors are able to treat the problems that they have that the so-called gatekeepers have no concept of.
Can we talk in controlling costs? Because that's really the purpose of so much of this is supposed to be controlling costs. And the ACOs, it builds a bigger bureaucracy. It just costs more money in paperwork and documentation and so forth. Can some of you guys in private practice talk about how much money you spend just complying with current government regulations, coding, CPTs, collections from patients, things that would go away if we did HSAs with high deductible insurance policy, put the insurance companies where they belong, get the government out of the insurance industry, separate the individual from the workplace for their own health care coverage, and put things in between the patient and the physician and leave it there. How much would you say?
I can't give you an exact number, but I can tell you that my practice employs 300 people. We have a large urology practice in Atlanta, Georgia.
How many doctors out of that?
37. And so we have, so that's you can figure out how many FTEs per doctor that is. Many of those people are there for compliance reasons, but 12% of our overhead is for actual physical plant, putting the lights on and rent and things like that. About another 10 to 15% are salaries. So the rest, is, you can, of a fit now, our overhead has gone from 42%, which it was about 4 or 5 years ago to about 52%. Some of that has to do with decreased reimbursements because the government has taken away certain things from us to make money, like seeing a patient in the office who is no longer a consultation because with the stroke of a pen, they decided that that CPT code does not exist anymore and they're not going to pay for a consultation, but at a lower level of service. And that's the kind of thing that happens when the government controls the payments and decides what your value is in the open market, how much your services are worth.
Can I follow that up then? So now you've kind of established that huge overhead costs, largely because you're complying with this bloated system that we would like to get rid of. If we went with the HSAs, you want to lower costs, think about how competitive physicians' rates could be in an open market system where we didn't have to pay for all this garbage. I mean, you're talking about you can potentially lower healthcare costs between the patient and the physician by 30% off the top.
Well, we know this from internal medicine doctors who've gone to concierge models. They've decreased their overhead, to about anywhere from 20 to 30%, depending on their office. So it's really unbelievable how bloated everything is because of regulations and everything that has to do with running a practice.
But all this, it's interesting. Also, I've been in practice for 20 years as an anesthesiologist, but I have to tell you, there's no coordination. I was talking to you guys before. The entire scenario from undergraduate through medical school through residency, and trying to put a grasp on what's involved. Again, most medical schools don't even teach the business of medicine. The financial burden you take on if you want to become a physician. How long it might take you to pay all that off, where medicine was, where it is, where God knows where it's going. And then there's a whole discussion always about cost. And I sit there and I get in conversations every day with patients. And they go, well, what's it like for you? I'm the wrong guy to ask that question for me. About 3 days we sit here and chat. But whose costs are we talking? I get crazy with it. I said, it's the government, you're right. Medicare, Medicaid, government costs, easy explanations. Their money and they decide what they're going to pay out. There's only so much in the pool. You start discussing about the health insurers and the whole managed care game that's been going on since it waved from West Coast to the East Coast. And how they manipulated everything. And then it's not just cost, it's their profits. And then what do you do with all that money that's been taken out of the system? And we've all been pumping ever since all that started. And how do you handle all that? And then with the account care organizations, they'd be pitting everybody against everybody else.
Well, I think in a national competitive insurance market, that kind of behavior is negatively rewarded. And I think that you have companies that, just like any other business, the companies that are willing and able to compete will thrive. Those that are unwilling or unable will go out of business. But to impose, by legislative fiat what companies are allowed to earn, to say what they must cover. We've already seen the implications of that. We've seen Provident get out. Is it Provident? Principal get out of the healthcare market entirely. They dropped almost 1 million people. Some of the Aetnas around the country getting out of the healthcare market, and they just can't do business, with the handcuffs on them. And they're a business, but again, I go back to saying what insurance has become in this country, and that's really the heart of the matter.
And I think the real problem with this legislation is it doesn't address the problem. I would contend the problem in medicine these days is too much government, not too little. We have 159 too many committees and bureaucracies as opposed to 159 too few. And furthermore, the very notion that Medicare, with its $30-some trillion in unfunded liabilities, is going to be a beacon in a haze of rising healthcare costs is just prima facie laughable. I mean, Medicare's record is, you know, striking, but it's really not that shocking. I mean, it's basically whatever the federal government gets involved in, whether it's the DMV, the post office, Amtrak, more recently AIG. Why would healthcare really be any different? And is this how we want to model 1/6 of the U.S. economy?
We have time for one more question or comment. Go ahead.
I'll take you up on the comment thing. I'm not a physician, I'm a health economist, and as Jason knows, I spend most of my time dealing with people who are health policy people. I was going to say experts, but health policy people who are not physicians, and usually came up through the ranks of a political organization or working with congressional staff, or learning about budgets and things like that. And they seem to have the two unspoken assumptions they may not even realize they're making, that I think that you as physicians have to understand, and this might help you when you talk to people. They tend to understand that each person has some unambiguous, maybe not obvious, but clear list of healthcare things they need, medically necessary services. A patient walks in, you say, here's the diagnosis, there's this list of what you need, and they don't seem to understand necessarily that when a patient comes in with a hurt knee, some people need this treatment, some people need that treatment, some people need the other treatment, and doctors could disagree on what's best for a patient. Patients might have an opportunity to choose between their preferences, between risk and invasiveness and things like that. And it's not you don't have an unambiguous list of what's medically necessary for each patient. And I think people don't understand that outside the profession as much as they need to. And that's why you get a system that says the Secretary of Health and Human Services will, by regulation, direct how you're supposed to practice, because they think it's obvious, and a doctor who's not doing what's obvious is doing it wrong. And since there's nothing that really is obvious, it's going to be defined arbitrarily. The second thing is they have this notion that each service has its particular cost. Each CPT code has some cost that's associated with it, and if it costs you more, you're being inefficient, and if it costs you less, then you're skimping and taking home too much profit, and they're going to cut your payment. And that's not true either. I shouldn't have to explain this to you. I shouldn't have to explain it to them either, because no other part of the world works this way either. But there's not such a thing as an unambiguous cost. There's not such a thing as an unambiguous list of services. And this is the kind of thing that I think from going to medical school, you understand this instinctively and don't realize that to a lot of people out there, it's not obvious. And I don't know, it something has to be explained.
Well, that's one of the goals, one of the principles of what we're doing. And, doctors have been absent from this debate for far too long. There's a lot of reasons why that has happened. We've been busy. We've been told that we're not good at business or we're not good at politics, and we should leave that to the professionals. Don't worry about other things; they'll take care of it. And we see what happens when we don't mind the store. So it may be too little, too late, but I'm hopeful that it's not, and that with enough doctors who get out there and tell the truth about what's going on, that we can fix things. So I'm going to call. It's 3:30, and I'd like to thank those of you who sat through this, and I hope that you got something out of it and enjoyed this symposium today. Thank you.